I'm happy to introduce Dr. Sushma SR, who has done her MBBS in Coimbatore Medical College and DNB and has done FNB in high-risk pregnancy and perinatology. She has worked in Mirabai Nursing Hospital, Kaveri Hospital, and Vijay Hospital, Hosur. She has passed her FNB in 2019 and has undergone 2 years training in Fernandez Hospital, Hyderabad. She has undergone training between 2017 and 19. She has secured 36 ranks in All India FNB exams in the entrance 2017. She has passed her DNB in 2016 and completed 3 years of training in Bangalore Baptist Hospital. She is an overall first-class distinction holder in Coimbatore Medical College during her tenure of MBBS. She has done paper presentations of more than 6 to 8. And she has attended international conferences with her paper Severe FGR, Perinatal Outcome and Maternal Outcome. I'm happy to introduce Dr. Sushma. She's here with us to talk about induction of labor. Over to Dr. Sushma.
Thank you for your kind introduction, ma'am. I thank OGSOK, Dr. Rekha ma'am, Dr. Sujata ma'am, and Dr. Anita ma'am for giving this opportunity. And today I'm going to present a journal club on methods for the induction of labor, efficacy, and safety. This is the most recent article released by ACUG in March 2024. So introduction.
Sorry to interrupt. Your screen is not seen, ma'am. Can you please share the screen?
2 minutes. Now is it fine?
Yes, ma'am. But please open the PPT, ma'am. You can
Okay.
minimize this.
I can minimize it, right?
Yeah.
Recently, in 2020 compared to 2017, there is a marked increase in rate of induction of labor, and this increase may have been contributed to this ARRIVE trial, which was done in London, which proved that it was done in 3,000 patients who were induced at 38 to 39 weeks, and 3,000 patients were put in the group of expectant management. This trial result showed that there is no adverse effects or difference in the perinatal outcome, and there was no increased rate of cesarean section when the women was induced at 39 weeks. So after this trial, there are increase in rates of IOL. So there are so many systemic reviews and meta-analysis which compares the effectiveness and safety of pharmacologic, non-pharmacologic, mechanical, and combined methods of cervical ripening and labor induction. So whatever be the method of induction, the condition of cervix is important to successful labor induction. So mainly the methods of induction of labor target either cervix by increasing the cervical ripening, or uterine contractility by inducing uterine contractility or by augmenting it, or certain methods target both cervix and uterine contractility. So first, coming to the pharmacologic methods, prostaglandins. Prostaglandins are formed from arachidonic acid liberated from membrane phospholipids via phospholipases A2 and phospholipase C. So mainly prostaglandin E and prostaglandin F play a central role in human parturition. When these prostaglandins bind to smooth muscle cells and decidua, uterine contractions result. These contractions cause degradation of collagen in the connective tissue of the cervical stroma, leading to cervical ripening. So first, coming to prostaglandin E1, otherwise known as Misoprostol. So as early as in 1980 to 1990, studies demonstrated the oral prostaglandin E1 the studies propose that oral PG even causes uterine contractions in early pregnancy. So in 1987, Mariani et al. Reported the use of oral misoprostol for labor induction. In 1992, efficacy of vaginal misoprostol in inducing labor during third trimester of pregnancy was done. So finally, the first randomized controlled trial comparing the safety and efficacy of intravaginal misoprostol was conducted in 1993. Initially, misoprostol was developed as a drug to treat gastric ulcers. Accidentally, it was found that when misoprostol was taken, uterine contractions resulted in women with pregnancy, and thus this use of misoprostol was found out. So, totally meta-analysis of first 8 trials was done with for labor induction with vaginal misoprostol. So it showed that there was a reduced incidence of cesarean delivery, shorter interval of vaginal delivery, and larger percentage of patients delivered within 24 hours. So structure and mechanism of action. Misoprostol is an orally active and chemically stable form of PGE1. Chemically, it is the methyl ester analog of PGE1, which prevents gastric ulcer. The active form of misoprostol is misoprostol acid. Misoprostol interacts with the EP receptors family, and EP receptor 1 and EP receptor 3 mediate contractility, whereas EP receptor 2 and EP receptor 4 mediate relaxation of the myometrium. Misoprostol mainly acts on EP receptor 3, mediating uterine contractility. So this you can see that on the membranes of the muscular cell. So there are 4 receptors, and the PG1 acts more on the EP receptor 3, which induces phospholipase C, which increases calcium and causes smooth muscle contraction. So pharmacokinetics. For the purpose of cervical ripening and labor induction, the misoprostol can be administered orally, rectally, vaginally, or sublingually. Sublingual and oral routes have quickest action onset of action. If we give misoprostol orally, the peak action is attained between 12 to 60 minutes, and there is a rapid fall of action by 120 minutes. But when we give vaginal misoprostol, maximum action is attained between 60 to 120 minutes, with 60% of the activity remaining at 240 minutes. But sublingual misoprostol has highest plasma level of concentration. So mainly that when vaginal misoprostol is kept, maximum action is attained after 1 hour. But when we give orally, it will attain within 1 hour, but rapidly the action falls after 2 hours. So dosage and methods of administration. In market, misoprostol is available as 100 microgram and 200 microgram tablets. Actually, misoprostol is not approved by Federation of Drug Association as a cervical ripening and labor induction agent. Usually it is used off-label, but ACOG recommends using 25 microgram doses of vaginal misoprostol, which redosing intervals of 3 to 6 hours. And WHO recommends usage of 25 microgram at 6 hours intervals. So recommended dosing for orally administered misoprostol is 25 to 50 microgram every 2 hours, maximum of 4 doses to 6 doses. So based on effectiveness, vaginal misoprostol, based on result of evidence-based publication, vaginal misoprostol at a dose of 50 micrograms compared with other dosages and routes of administration has the highest probability of achieving vaginal delivery within 24 hours. So complication and side effects. Main complication is the tachysystole, increased uterine contractions with or without association of fetal heart changes, increase in meconium stain fluid. It is mainly because of the action of misoprostol on fetal gut. So sometime when given in a patient with trial of labor after cesarean, there is increased chances of rupture. Usually the normal rate of rupture in TOLAC is 1 in 100 women. But when we give misoprostol, the rate raises to 3 to 4 per 100 woman who is undergoing TOLAC. So ACOG recommends against the use of misoprostol in the third trimester of pregnancy for patients with uterine scar. So usually the common side effects for misoprostol is fever, chills, and diarrhea. It's usually associated only with higher doses. For the doses that we use for induction and cervical ripening, these side effects are usually not present. Next, coming to Dinoprostone PGE2 and Dinoprost PGF2 alpha. Initially, both agents were used for cervical ripening, but later it was found that PGE2 is more effective than PGF2 alpha. Hence, trials of PGF2 alpha was stopped, and only trials of Dinoprostone got released. Use of Dinoprostone is reported 50 years ago. PGE2 was more effective than PGF2 alpha. So vaginal route is more efficacious with least number of side effects. So initially there was extra amniotic injection of PGE2 gel and small slices of 20 milligram PGE2 suppository was used intravaginally. It was later abandoned because of increased incidence of uterine taxistole. Currently, PGE2 is the only prostaglandin approved by FDA for cervical ripening and labor induction. So a mechanism of action, they also bind to EP receptors and cause myometrial contractions and stimulates collagenous secretions, leading to decrease in collagen helices within the cervix. How the exogenous prostaglandin act is by cervical ripening by disorganization of collagen, vasodilation, increasing the stromal leukocytes, and release of pro-inflammatory cytokines, which in turn breaks the collagen helices within the cervix, leading to cervical ripening. So after vaginal administration, synthetic PG2 has a plasma half-life of only 2.5 to 5 minutes. So dosage and methods of administration. There are different methods available in the market, but all of the dinoprostone should be kept frozen till we apply it to the patient to maintain its efficacy. Cervidil is a slow release suppository placed in the vaginal fornix. 10 milligram suppository releases 0.3 milligram of dinoprostone every hour. It should remain in place for 12 hours and can be repeated every 12 hours. Patient must be in recommend position for 2 hours after placement. It must be removed 30 minutes before starting oxytocin. Lubricants should be avoided when we are keeping the suppository, as lubricants prevent the sustained release of this medicine. So the other is Propes. In India now this Propes is available, and this method is being increasingly used nowadays. It is a pessary vaginal delivery system. It was developed to reduce the number of applications and vaginal examination. Propes is a biodegradable polymeric drug device containing 10 milligram of dinoprostone within the matrix, releasing 0.3 milligram of dinoprostone per hour. It can remain in place for 24 hours. It also must be kept in freezer until just before insertion, must be placed in the posterior vaginal fornix, must be removed before 30 minutes before initiation of oxytocin. This is increasingly used nowadays in India. The only advantage is minimal vaginal examinations, but the outcomes are as efficacious as intracervical gel. So what we use is the cervical administration gel. Here we have the trade name as Cerviprime. So this also must be stored in a refrigerator, but can be administered at room temperature. Here it contains 2.5 ml of 2.5 ml contains 0.5 milligram of dinoprostone inserted in the cervical canal just below the internal os. Dose of 0.5 milligram can be repeated every 6 hours up to 1.5 milligram in 12 hours. So maximum 3 doses can be given at 6-hour interval. Patient must remain recumbent for 15 to 30 minutes after the gel is placed. Before initiating oxytocin, 6 to 12 hours should elapse after the placement of dinoprostone gel. With the previous methods, it's only half an hour, but with the gel, at least 6 to 12 hours should elapse. So both intravaginal and intracervical application has similar efficacy. So effectiveness. So Cochrane review noted that all forms of PGO2, regardless of dosing and time interval between dosing, seem to be as effective as each other in decreasing the cesarean delivery rates. Complications and side effects, as such, there is no documented complication or side effect. Nausea, vomiting, and diarrhea. In some patients, we can see temperature elevation. Uterine tachycystole is present for all the agents of induction of labor. In case of uterine tachycystole, we can remove the applied gel, or we can remove the pessary or the Propus matrix. So next, coming to oxytocin. Oxytocin was identified by Sir Henry Dale, who extracted this molecule from posterior pituitary of oxen, and then later it was based on the oxytocin means quick birth in Greek, and William Blair Bell was the first to test pituitary extract containing oxytocin for stimulation of human labor. But this was the oxytocin which was derived from oxen. Because of unpredictable uterotonic effects and vasopressin like properties, there were a lot of side effects, and it fell out of favor. Only in the 1950s, the synthetic version of oxytocin was developed by D. Vinegar and colleagues, allowing for dose titration and control of oxytocin's uterotonic effect. And that synthetic version of oxytocin was named as pitocin. So synthetic preparation of oxytocin was required to avoid the cross-contamination with vasopressin. So structure, it is a 9 amino acid cyclic neurohypophysical peptide with a disulfide bridge between cis residues 1 and 6. It is composed of 6 amino acid cyclic portion and a COH terminal alpha amidated 3 residue tail. Chemical structure of oxytocin differs from the closely related pituitary hormone vasopressin only by the amino acids at positions 8 and 3, likely accounting for some overlap in antidiuretic activities. So this is important because this may present as a side effect when we use increased concentration of oxytocin for prolonged duration. So mechanism of action, oxytocin acts on oxytocin receptor. It couples with GAQ11 G family proteins, G group family proteins, which in turn couples with phospholipase C beta, which causes chain of reactions causing phosphoinositide biphosphate to hydrolyze into inositol triphosphate and diazyl glycerol, which in turn increases the calcium levels inside the cells, leading to activation of calmodulin and myosin light chain kinase. Eventually, contraction ensues, leading to uterine contractions. So, oxytocin is synthesized in the paraventricular nucleus and supraoptic nucleus of hypothalamus and is released into circulation by posterior lobe of pituitary. This is endogenous oxytocin. Oxytocin is involved in various reproductive processes like modulation of uterine contraction during parturition, milk ejection reflex during breastfeeding, and functioning as a neurotransmitters involved in maternal behavior. So exogenous oxytocin, onset of action we can see within 3 to 5 minutes with a half-life of 1 to 6 minutes. Because of relatively slow onset of action, 40 minutes is required to reach a steady state. Additional oxytocin may be given before the full effects of previous dosing are known. So uterine responses to oxytocin depends on dose of oxytocin, the receptor expression present in the particular patient, and post-receptor metabolism. Oxytocin is metabolized and excreted by maternal kidney and liver. So in case of a patient who has liver failure or kidney failure, dose of oxytocin should be titrated and half dose oxytocin to be given, or low dose regime to be followed. After discontinuation of the drug, uterotonic effect may be expected to persist for approximately 1 hour. So this is the low dose and high dose oxytocin regimens for labor induction. So low dose, we usually follow the drop method. First, I will tell what we are using. Then we can correlate with whether we are using low dose or high dose regimen. So we usually put 5 units in 500 ml of RL. So 5 units means 5000 milliunits. In 1 ml, there will be 10 milliunits. So 1 ml, 4 drops is equal to 1 ml. So when we keep 4 drops per minute oxytocin, we are usually given 10 milliunits per minute. So actually we are giving more than high dose regimen. If you see low dose regimen is 0.5 to 2 with the interval of increasing is 15 to 40 minutes with the increment dosage of 1 milliunit per minute, 1 to 2 milliunits per minute. In high dose regimen, the starting dose is 6 milliunits per minute. With the same interval, we can increase the 3 to 6 milliunits per minute. So usually when we see, if we increase the oxytocin drip at a rate of half an hour to 40 minutes, if we increase by 4 drops also, we are increasing at a higher rate as far as I know. So Cochrane review showed high dose oxytocin regimens were associated with a shorter induction to delivery interval, and high dose oxytocin regimens were associated with more uterine hyperstimulation than low dose oxytocin regimens. There was no difference in cesarean deliveries between regimens. So efficacy of both low dose and high dose oxytocin remains the same. So the Cochrane review of IV oxytocin for cervical ripening and labor induction combined findings from 61 randomized trial, including 12,000 patients, that compared oxytocin with either no intervention or cervical and vaginal misoprostol. So when compared with the expectant management, oxytocin was more likely to deliver vaginally within 24 hours. But when we compared the women who used oxytocin with the women who used vaginal progesterones, the women who were induced with vaginal prostaglandins gave better results. So when IV oxytocin and oral misoprostol was compared, so the likelihood of oral misoprostol to not achieve vaginal delivery then was similar to that of IV oxytocin. So if we induce the patient with oral misoprostol or IV oxytocin, the efficacies of both are same. But when we use vaginal misoprostol and we compare it with IV oxytocin for induction of labor, the group which used vaginal misoprostol was more likely to attain vaginal delivery within 24 hours. So, the more recent network meta-analysis found that IV oxytocin combined with amniotomy had lowest probability of vaginal delivery not being achieved within 24 hours. That means it shows high probability. So, the probability of oxytocin plus amniotomy is amongst the 3 most effective labor induction methods among the 34 methods studied, and was estimated at 88%. So if we use only oxytocin without amniotomy, it was ranked at 15th position. When we use oxytocin with amniotomy, it comes in the top 3 effective methods of labor induction. So complication and side effects, we can expect anaphylactic reactions. Some patients can land up in cardiac arrhythmias, including premature ventricular contractions. There may be nausea and vomiting, pelvic hematoma, or subarachnoid hemorrhage. The reason for all these things were not mentioned, but there may be hypertensive episodes. When we use oxytocin in a grand multiplara, some cases of uterine rupture was reported. Prolonged or high dose IV infusion of oxytocin may lead to water intoxication and hyponatremia. So because the structure of ADH or vasopressin and oxytocin are similar, oxytocin has similar effects of vasopressin. Hence, when we give prolonged infusion of oxytocin for a very long period, we should look out for hyponatremia. If we have used prolonged dose, this complication is a bit common. So most reported adverse effects is uterine tachycystole or excessive uterine activity. The advantage with oxytocin is once we stop the drip within a maximum of 1 hour or within minutes, because the half-life is only 6 minutes, we can decrease the uterine activity. So oxytocin has an unpredictable therapeutic index because the dose of oxytocin and the effectiveness of oxytocin depends upon the receptor presence over the uterus, which is variable in every patient. So this unpredictable therapeutic index led the Institute of Safe Medication Practices in 2008 to add oxytocin to the list of high alert medications that bear a heightened risk of harm when used in error. Next, coming to Mifepristone, it is also known as RU486. It is a progesterone antagonist known to cause softening and dilatation of human early pregnant cervix and increased uterine activity. So initially, it was used only for termination of pregnancy in intrauterine demise. A 2009 Cochrane analysis identified 10 clinical trials inclusive of 1,108 patients, which compared the efficacy of Mifepristone to placebo. So people who took Mifepristone were more likely to have a favorable cervix at 48 hours, less likely to need oxytocin augmentation, and less likely to require cesarean delivery for failed labor induction. So 2,200 milligram oral tablet of Mifepristone is the lowest effective dose for cervical ripening, reaching the optimal effect at 72 hours. In the above analysis, 400 milligram of Mifepristone was used. So the main drawback was that abnormal fetal heart rate patterns were noted to be more common with the use of Mifepristone than with the use of placebo, but no adverse neonatal outcomes were noted. Hence, this drug usually is not used when the baby has heartbeat. It is usually tried only in intrauterine demise. So, several studies have compared Mifepristone with non-pharmacological mechanical strategies. Induction to delivery interval and pain-related cervical ripening were significantly reduced with the use of Mifepristone compared to the use of laminaria. In a study comparing the use of Mifepristone, single 400 milligram oral dose with the placement of Foley's catheter, for women with one previous cesarean delivery and post-term pregnancy, Mifepristone was associated with a reduced interval to onset of labor, improved the Bishop scores at 24 hours, reduced the need of oxytocin, reduced the incidence of failed labor induction, but there was no difference between the groups was noted in overall cesarean delivery rate. So a trial was also done comparing 200 milligram of orally administered Mifepristone with PGE2 gel. Dinoprostone significantly improved initial change in Bishop scores and reduced labor induction initiation to active labor. So pre-treatment with Mifepristone may be advantageous because of its long half-life. Next is Relaxin. Relaxin is a polypeptide protein produced by corpus luteum. It plays crucial roles in implantation, tissue remodeling, collagen relaxation, inflammatory modulation, vascular changes during pregnancy. Levels of relaxin are highest in early pregnancy and decreases as gestation progresses. So studies in mice have shown that this hormone is involved in cervical ripening by reducing the density of collagen fibers, altering aquaporin expression, and increasing hyaluronic acid in the cervix. But when intravaginal relaxin gel was tried, no difference was found between modified Bishop score or length of first or second stage of labor and oxytocin requirements. When IV administration of relaxin was used, that also did not result in any significant change in Bishop scores at 6, 12, and 24 hours. So Cochrane did an analysis in 2001 for the use of relaxin as a cervical ripening agent, but it noted a significant reduction in women with unfavorable cervix treated with relaxin compared with placebo. However, no difference was noted with cesarean delivery rates. Next is hyaluronidase. It is an enzyme that breaks down hyaluronic acid into monosaccharides by cleaving its glycosidic bonds. Hyaluronidase increases tissue permeability by the viscosity of hyaluronic acid. Initially used in obstetrics to decrease the frequency of perineal tears, pains, and need for episiotomy. FDA has not approved hyaluronidase as a labor induction agent or cervical ripening agent. It has approved hyaluronidase for several other indications like absorption and dispersion enhancer of administered drugs, subcutaneous fluid administration for hydration therapy, and subcutaneous urography to improve the absorption of radiopaque agents. But hyaluronidase does not induce uterine contraction. It is used solely as a cervical ripening agent. So a controlled randomized study was done which compared intracervical administration of hyaluronidase. Patients who received hyaluronidase were less likely to have unfavorable cervix at 24 hours, less likely to have oxytocin augmentation. There were significantly lower rate of cesarean delivery. And another RCT compared the intracervical administration of hyaluronidase with the use of Foley's catheter. Both methods were effective for cervical ripening with no adverse reactions noted. There was no significant difference in Bishop score, induction duration, and amount of oxytocin needed to attain delivery between the study groups. The cesarean delivery rates were significantly higher in women receiving hyaluronidase than those using the Foley's catheter. So, although intracervical injections of hyaluronidase may effectively promote cervical ripening, the need for intracervical administration may limit this interest. How to administer hyaluronidase? It is commercially available as vials which contain 200 USP of ovine hyaluronidase per ml. The dose used for cervical ripening is 20,000 units of lyophysated hyaluronidase diluted in 5 ml of distilled water, and we have to separately take two syringes with 2.5 ml, and each syringe is infused in anterior and posterior lip respectively. No side effects has been reported in the mothers or neonates. Next is nitric oxide donors. It is a free radical with ultra short half-life synthesized from L-arginine by enzyme nitric oxide synthase. It is endogenously synthesized in cervix and placenta during pregnancy. So the interplay of nitric oxide with prostaglandins is integral to the maturation pathways leading to cervical ripening. So Cochrane did analysis in 2016 and evaluated intravaginally administered nitric oxide donors, that is isosorbate mononitrate, isosorbide nitroglycerin, and sodium nitroprusside for third trimester cervical ripening or labor induction versus placebo, and vaginal PGE2, intracervical PGE2, vaginal Misoprostol, intracervical Foley's catheter. So compared to the use of placebo, the nitric oxide donors was associated with a reduction in unfavorable cervix at 12 to 24 hours. However, the vaginal delivery within 24 hours and cesarean delivery rates were similar in both placebo and nitric oxide donor group. Compared with vaginal and intracervical prostaglandins, the use of nitric oxide donors was associated with decreased proportion of women not delivering within 24 hours. But when used with vaginal Misoprostol, the NO donors group use was more associated with the need for oxytocin induction, reduction in the rate of uterine hyperstimulation with or without fetal heart rate changes. But this is not the main drawback. Overall, for all comparisons, women receiving nitric oxide donor treatment, generally isosorbate mononitrate, reported more higher incidence of side effects, which included nausea, headache, and hyperemesis. This is because of fluctuations in BP. So coming to mechanical and combined methods, in 1855, Braun was the first to demonstrate that rubber balloon could be used to dilate the cervix. So later, Mattei used water-filled balloon made out of sheep bladder, and his report is considered the forebearer of the use of single balloon catheter, that is Foley's catheter, for pre-induction cervical ripening. So in 1967, Embray and Mollison applied a 26 gauge Foley catheter inflated with 50 ml of sterile water inside the cervix for the purpose of pre-induction cervical ripening. In 1977, a double balloon trans-cervical catheter was described by Attard and is now commercially available as Cook's cervical ripening balloon for pre-induction cervical ripening. So the double balloon catheter alone was compared with Dinoprostone gel with two balloons, and there was no significant difference in increase in Bishop score. So it was determined that the catheter alone was as effective and well tolerated method for cervical ripening and labor induction. So the mechanism of action seems to be due to application of pressures on both internal and external cervical os with pressure vectors in the direction of the cervix. Next, coming to Foley's catheter. The Foley catheter was first proposed for outpatient cervical ripening in 2001. Compared with inpatient cervical ripening, those receiving a single balloon catheter in outpatient setting had shorter intervals from admission to delivery, lower rates of cesarean delivery. There was no difference in adverse maternal and perinatal outcomes. The studies in aggregate had limited power to find sufficient differences in outcome between the two study groups. So the structure of Foley catheter is relatively standard. The gauge is typically between 16 and 26 with inflation balloon volumes of 30 to 80 ml. The materials used for Foley's catheter are latex or silicone rubber based. The Cook's catheter is made of silicone. The primary means of cervical ripening with mechanical methods is through physical forces dilating the cervix. The downward forces applied with the Foley's catheter. In addition, inflammation and prostaglandin release play roles in cervical ripening process. So, along with the mechanical methods of dilatation, extra amniotic saline infusion has been added to both the Foley and Cook catheters to potentially increase the separation of the decidua from the uterine wall, theoretically increasing the prostaglandin release. Combining the use of Foley catheter and extra amniotic infusion may decrease the time to vaginal delivery and rate of cesarean delivery. So, administration and application, the Foley's catheter can be applied with the use of speculum or during digital examination. Once inside the cervix, traction, it is inflated with 30 to 80 ml of saline or sterile water, and traction is commonly applied by taping the end of a catheter to inner thigh. However, this practice has not been found to enhance efficacy in cervical ripening and labor induction. So, the Cook's double balloon catheter is generally placed with a speculum and inserted with the provided stillet. The catheter is inserted until the second balloon is in the cervical canal. The upper balloon is inflated with 40 ml of saline. The traction is applied to this catheter until the first or the upper balloon is in contact with the inner cervix. The second lower or vaginal balloon is inflated with the 20 ml of saline. The speculum is removed and each balloon is filled with 20 ml increments of saline until both balloons contain 80 ml of fluid. Double balloon catheter costs more, which is a significant disadvantage. So usually it costs around 2,500 to 3,000 rupees, and it is a single usage catheter. However, the double balloon catheter is FDA approved, whereas Foley's catheter is off-label when used for cervical ripening. The combination of Foley's with AC is performed after the catheter is inserted, but after attaching an IV bag of sterile saline on an IV pole to the end of the Foley's catheter. So, effectiveness, mechanical dilators are as effective as Misoprostol and prostaglandin gel for pre-induction cervical ripening. Foley's plus extra amniotic infusion seems to have similar effect as that of Foley's alone. So, early amniotomy resulted in faster delivery times without an increase in cesarean delivery rate. Simultaneous use of single balloon catheter and oxytocin compared with the use of catheter alone significantly reduced the interval from induction to delivery. In all the randomized trial, it was proved that when we keep Foley's, vaginal misoprostol enhances the efficacy of pre-induction ripening compared to buccal misoprostol. So all methods of combination like Foley's with oxytocin or PGE1 or PGU2 were found to be similar concerning the efficacy and safety. So two types of catheter have similar efficacy, safety, and patient satisfaction levels. Adverse effects, we think because it is invasive there is increased risk of infections, but in all the trials this didn't show any increased risk of infections. Use of Foley's in women with rupture of membranes, there were two schools of thought. When certain studies showed no increase in rate of infection, but certain studies shows increased rate of infection. So concern regarding, so because we use mechanical dilatation, concern was there regarding the damage of cervix and increased rate of preterm delivery in the next pregnancy. Studies proved that there is no such correlation. And next, coming to laminaria and hygroscopic dilators, it has been used for almost 100 years. Laminaria are naturally occurring sea plants that slowly absorb moisture and expand when placed in the cervix. Dilapan is a synthetic hygroscopic cervical dilator, has been used before the termination of pregnancy for decades and has been found to be superior to other synthetic cervical dilators. Dilapan, yes, was shown to be effective for pre-induction cervical reddening. Structure and mechanism of action. Dilapan S is composed of aquacryl, a synthetic hydrogel that slowly absorbs moisture and expands for hours. Primary means of cervical whitening with mechanical methods is through physical forces dilating the cervix. In case of hygroscopic gel and laminaria, it is the circumferential forces which acts on the cervix. In addition, inflammation, prostaglandin release play a role. Dilapan S hygroscopic dilators and laminaria are inserted using sponge forceps while using a vaginal speculum to directly visualize the cervix. Individual rods are inserted into the cervix and until achieving a tight fit. Depending on the baseline cervical dilatation, 2 to 5 rods of Dilapan S are inserted within the endocervical canal. The dilators are left in place for approximately 12 hours while the rods expand, slowly dilating the cervix. The rods are removed with sponge forceps and the removal of each dilator should be documented. So in the figure, you can see that the laminaria is a single rod. The position you have to see, it has to be just at the level of internal os. When we push the laminaria more into the internal os, there is more chances of artificial rupture of membranes. On the right side, you can see the Dilapan S insertion for labor induction. So next is membrane stripping or sweeping. Membrane stripping or sweeping is reported in literature like 225 years ago. It involves either a circular reaming or a scratching of membranes with the provider's finger. Stripping is believed to disrupt the decidual uterine interface at the lower uterine pole and elicit the release of procervical softening molecules such as collagenases and prostaglandins. The efficacy of membrane stripping is performed only after 36 weeks. Evidence from systematic reviews with meta-analysis remains unclear. However, the apparent absence of adverse effects suggests safety. In general, membrane stripping stimulates the spontaneous onset of labor and decreases the post-date delivery and the need for subsequent medical induction. The advantages of membrane stripping include that it is inexpensive, easy to perform, and convenient. The contraindications of membrane stripping include rupture of membranes, presence of any active infection, positive group 3 streptococcus carriers, or placental abnormalities such as placenta previa, placental abruption, and vasa previa, and vaginal bleeding of unknown etiology. Coming to amniotomy. Amniotomy or artificial rupture of membranes was introduced as a labor induction method by Persians in 11th century. Amniotomy stimulates oxytocin release from the pituitary gland followed by release of prostaglandins locally. After assuring that there is no contraindication to amniotomy like active herpes, HIV, vasa previa, or phonic presentation, and confirming the fetal presentation and station, accessible membranes are snagged and ruptured with the use of plastic hoop. We can do it digitally also. Patients randomized to undergo amniotomy with oxytocin were more likely to deliver within 24 hours and less likely to require operative deliveries than patients randomized to undergo amniotomy alone. So adverse effects include prolapse of umbilical cord, chorioamnitis, prolonged interval to delivery, and maternal discomfort. Coming to complementary methods, common complementary strategies include nipple stimulation, sexual intercourse, castor oil, herbal supplements, and acupuncture. So, initially, because of inadequate data assessing their efficacy for labor induction, lack of standard dosing or use, and proper possible adverse events, these complementary approach to labor inductions have been resolved only for low risk obstetrical patients on individualized basis. So, nipple stimulation. 2005 Cochrane meta-analysis of 6 small trials, including 719 patients, found a significant reduction in number of patients not in labor at 72 hours. Moreover, the authors found no difference in cesarean deliveries, meconium-stained amniotic fluid, or hyperstimulation when nipple stimulation was compared with no treatment. So, particularly it is safe. So another study comparing the uterine activity produced by nipple stimulation and oxytocin infusion in a group of patients at term admitted for labor induction. A significant increase in uterine activity occurred in both groups. However, regular uterine activity was achieved more rapidly in nipple stimulation group, but the uterine contractions were less intense. So the mechanism of action of nipple stimulation is similar to that of oxytocin reflex. When you stimulate the nipples, it activates the oxytocin reflex in posterior pituitary, releasing more oxytocin, hence contractions. So because of that is we don't know the proper we cannot judge the amount of contractions that the patient gets based on nipple stimulation. So some may get increased contraction, some may not get increased contraction. So the use of breast stimulation may be appropriate only for low risk patients. Sexual intercourse has been frequently used as a complementary method for cervical ripening and labor induction. Its possible effects may be related to the release of oxytocin associated with nipple stimulation and orgasm, and possibly the direct action of seminal fluid prostaglandins on the cervix. This is the theoretical justification that they give. But when it was tried, seminal fluid from male ejaculate has been observed to increase the prostaglandins levels in the cervical mucus 10 to 50 fold within 2 to 4 hours after ejaculation, which persisted for up to 12 hours. But the reports of RCT found no difference in labor onset, and the need for induction was observed. So castor oil, this is the extract from Ricinus communis and is oil consisting of richolin acid. In early 1950s, over half of US academic obstetrical departments surveyed use either orally administered castor oil singularly or in combination with soap suds enemas. After the advent of pharmacological agents, the use of castor oil is now obsolete. The recent systematic review and meta-analysis concluded that oral administration of castor oil is effective for cervical ripening and labor induction. The exact mechanism of action has yet to be fully understood, but given gastrointestinal symptomatology, a prostaglandin mediation has been suggested but not confirmed. Potential complications from castor oil include meconium staining and maternal electrolyte abnormalities from diarrhea. Herbal supplements. The most common herbs for labor induction include raspberry leaves, primrose oil, and blue and black cohosh. Primrose oil is used by orally ingesting tablets of various concentration up to 3 times daily for a week. Black cohosh liquid is administered orally at 10 drops every hour until labor begins. The time from initial ingestion to observing ripening effect is reported to be as little as 4 hours. Blue cohosh is a tincture of 2 to 8 drops in warm tea or water. It is repeated every 30 minutes until the initiation of uterine contractions. Sublingual administration has been suggested and consists of 1 teaspoon of placed under the tongue every hour for a maximum of 4 doses. So raspberry leaves consumed in tea have been suggested to promote synchronous uterine contraction, but there is no standard dosing or regimen. So clearly well-controlled research efforts will be required to assess the efficacy and delineate risk, if any. Until such a time, it is best to avoid recommending herbal supplements during pregnancy. There were so many trials conducted in which only the cohosh derivatives caused changes in fetal heart rate. Hence, it should be avoided. Acupuncture. Acupuncture involves the insertion of a thin needle into designated neural locus and is felt to have a distant effect on a biological system or organ. Controlled and observation studies have reported uterine contractions occurring in 68% of exposed pregnancy. When electrical stimulation was applied via acupuncture needles, uterine contractions were observed in more than 90% of the patients. But the disadvantage of acupuncture include the requirement of trained providers and lack of well-conducted research with adequate sample size. So totally to see the complementary methods. So the acupuncture, the dose and route is done as per the provided. It can be done daily Black cohosh is given sublingually 10 drops. Blue cohosh oral 2 to 8 drops. If there is any allergy, we should avoid it. Castor oil 60 ml is mixed with beverage of choice, and it is been given only once. Membrane stripping, nipple stimulation is membrane stripping is intracervical and done as needed. Manual or mechanical via breast pump nipple stimulation 3 times a day for 1 hour as needed. Contraindications is high risk pregnancy. Primrose oil oral 1 capsule every 8 hours up to 4 weeks. Red raspberry leaves orally 2.4 milligram every 8 hours until the onset of uterine contraction. Sexual intercourse variable duration. So, coming to labor induction in twin pregnancies, in a 2006 retrospective case study, the authors evaluated the use of 100 microgram of oral misoprostol uh, in 69 nulliparous patients with twin pregnancies of at least 35 weeks gestation. They reported that 76.8% of patients had vaginal delivery, 4.3% has combined twin delivery, and 18.8% required a cesarean birth, but no cases of uterine hyperstimulation or uterine rupture was reported. Another study was done comparing the safety and efficacy of intravaginal misoprostol to oxytocin for induction of labor in twin pregnancies with a gestational age of at least 34 weeks. The authors reported a shorter length of induction to delivery and trend toward lower cesarean delivery rate in oxytocin only group. There was no cases of uterine rupture or maternal mortality, and there was no significant differences in neonatal outcomes between the two groups. Although oxytocin is widely used for labor induction in singleton pregnancies, its use in twin pregnancies has been associated with concerns of increased risk of uterine hyperstimulation and subsequent uterine rupture. Due to paucity of high quality evidence on safety and effectiveness of labor induction methods in twin pregnancy, careful consideration is needed to weigh the potential risks and benefits of each method. Methods of induction in gland multiparous patient. Gland multiparity defined as 5 or more previous pregnancies at a gestational age of 20 weeks or more. It is associated with increased risk of pregnancy and childbirth complications, including preeclampsia, gestational diabetes, placenta previa, fetal macrosomia, and postterm delivery. Intracervical application of PGE2 may be safe and effective method of labor induction in gland multiparous patient. Several studies have used vaginal misoprostol for induction in gland multiparous, and no incidents of adverse effect, including uterine rupture, were noted. So, it is crucial to conduct high quality research to provide evidence based recommendation for labor induction in this population. Thank you. Madam, it was a very vast topic. Actually, the article was some 27 to 30 pages. So I had to cut short a lot and I was a bit fast. I'm really sorry.
Yeah, ma'am. It was so elaborative. You started off with the initial methods, you went on to medical, mechanical, so many methods, and everything you went into detail, the dosage, the timings, the precautions, the contraindications. It was really, as you say, it was too much for this time, but you have covered all the important aspects. It was really nice. And the double bubble catheter, did you show the picture? Because I don't remember seeing it because we have not seen one. Did you show it today?
Yes, madam. 1 minute, I will show.
It was not actually that you said that is approved actually, no?
Yes, madam. Actually,
So,
its usage
is it in use nowadays here?
Yes, ma'am. Actually, it is used in Fernandez Hospital, ma'am, and the results are really good. We usually
That's right.
apply. 1 minute, ma'am. I'll just get the picture
Yeah.
here.
Wait.
A very extensive presentation, Sushma, and I think we've revisited the basics and revised everything. Most of us, I think, are refreshed with induction of labor with a lot of updates.
Thank you, ma'am.
But I think most of us are not very experimental with induction of labor. We usually stick to something that we're already comfortable with.
Ma'am, nothing like that, ma'am, because we see high risk pregnancies, most of us. All easily delivering patients, they land up in GH.
Correct.
So we have no choice. We are forced to see high risk cases.
Correct.
Madam, can you see, madam, the catheter?
Yes. This is nice.
There are two different colors for two different balloons, ma'am. So
Yes.
initially we will insert this part of the balloon inside the cervix, and we will infuse 120 ml and see if the patient has any pain or not. Then if the patient doesn't have any pain, then we will proceed. Then we will pull it and plug it against the internal os. Then we will inflate the second one with 20 ml. And like they have mentioned, 20 ml we will be adding in each balloon, seeing the patient's pain thing also. And we will be having NST also, ma'am. Sometimes 80 ml will be too much, and the separation of membranes will be too much. Sometimes there may be fetal heart rate decelerations also. So that time we have to remove the amount of fluid, ma'am. So in between these two balloons, the cervix will be there, and once we remove, we will usually keep it for 12 hours, and we used to take CTG after every 4 hours, ma'am. And then once we remove, they will be usually dilated to 3-4 centimeter actually every patient. But when we re-examine after 2 hours, they will come down to 2 centimeter. So we used to keep hooks followed by 3 doses of Cerviprime gel.
Okay,
So
combined
it was
methods.
very effective, ma'am. This was very effective. Even after examining after 2 hours, if the cervix was 3 to 4 centimeter, we used to proceed with ARM and oxytocin.
Combined. Yes, ma'am. Thank you, Sushma.
Okay, madam.
This
And
is
even
really nice.
Opus, they are using in Fernandez now, ma'am. We will keep, we will do a pre-CTG and we'll keep Propus, and we will take CTG every 4 hours. But the result is very good, ma'am.
Okay, okay.
Uh,
Induction.
but the tachysystole is there, but most of the patient deliver in the 24 hours only. No need for oxytocin also. They will deliver,
Yes.
ma'am.
Yes, Sushma, your speech was so elaborative. Ideal selection of the patient, proper induction methods, watching the patient carefully for complications, and intervention in the right time. I think all this is important for a successful induction. Your topic has covered all that, and it is really useful. Thank you, Sushma.
Thank you so much, madam. Thank you so much.
There is a question in the chat box, Sushma. Induction in twin, is it safe? Aruna's asked.
Usually, in practical practice, we don't induce, ma'am. We when they come at 37 weeks, when it is DCDA twin and low risk, when they come at 37 weeks, they will already be because of the stretch of uterine uterus, they'll already be usually patulous os with 1 to 2 centimeter dilated. And when I was a PG, we used to give Cerviprime gel only, ma'am. Cerviprime gel every 6 hours we used to give. But in this study also, they told PGE2 is the safest for twin pregnancy. Cerviprime gel.
Yes.
Is the question answered, ma'am?
Yes, ma. But as such, and twin itself is a high risk pregnancy, because nowadays we
Yes,
see,
ma'am.
even we are answerable for any anemia. If there is history of abortion, we are answering now, no, for all the government reviews, no.
Yes, ma'am.
Anemia, high risk. Previous abortions, high risk. So I think for twin pregnancy nowadays it becomes a high risk.
No, in
So
the
I think
study
proper
also it is
selection is
given
important.
that the rate of normal vaginal deliveries have decreased in twins recently,
Yes.
and the rate of cesarean delivery directly is increased.
Yes. Yeah, I think it's possible in institutes, as Sushma rightly said. I
Yes,
think
ma'am.
Fernandez, yes. Your training hospitals have done wonderful work, I think. That confidence which you speak, no, that really matters.
Yes, ma'am.
Hats off, Sushma. They're doing well.
We are exposed to all sort of cases, ma'am.
Yeah,
So
yeah.
and basically, this is an ACOG article, but they do everything based on RCOG, ma'am. So in
Okay.
RCOG, the laminaria and this hygroscopic dilators, they are all contraindicated because it increased the vaginal infection rates. So in RCOG, they don't use this vaginal, that is dilator, cervical dilators, they won't use.
Okay, ma'am. Okay. Okay. Thank you, Sushma. Thank
Thank
you.
you,
It
ma'am.
was
Thank
very.
you, ma'am.
Yes. Thank you. Thank you for a wonderful
Welcome, ma'am.
presentation,
Thank you.
Sushma.
Thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you, Chitrakala, and thank you, Shield, for supporting us for this.
Yes, ma'am.
Thank you, ma'am.